Welcome to Spotlight on Authors. I'm Kathy Andolsik, Professor of Community and Family Medicine at Duke and an Associate Editor of the Journal of Graduate Medical Education. These interviews give our readers an opportunity to listen to our authors and hear them describe their work in their own words. Today, it's truly my pleasure to introduce to you Dr. Haywood Brown, who's chair of our Department of Obstetrics and Gynecology at the Duke University School of Medicine, and to hear Dr. Brown discuss his most recent study, the incidence of cesarean operative times following institution of the 80-hour workweek. So what piqued your interest in studying this topic?
Well, Kathy, you know I've been involved in medical education for a long time, and as a surgeon, I've lived through the pre-duty hour and the post-duty hour phases. And just anecdotally, I noted that it took a little longer for our junior trainees to kind of finish a cesarean procedure. And we decided to study it.
And what are the practical implications of your findings for both our program directors and our residents?
The practical implications really are around the fact that even though residents get very good at doing things with the same number of procedures, it takes them a little longer to get there, primarily because they are not around as much as they used to be. Maybe they don't do as many procedures early in their course as they used to. And those are the practical implications around something like this. And it quite honestly is very similar to studies that have been done in GYN recently, looking at laparoscopic surgery and how it takes a little longer to get that level of proficiency very early in your training compared to later in your training.
So what were some of the positive things that you learned?
The big positive of this is that when we broke the study out, looking at how long it takes from the incision to delivery, that there was absolutely no difference in that critical period of getting the baby out, irrespective of BMI, irrespective of all other factors. When the cesarean was called, making that incision, getting the baby out was exactly the same for the junior residents as it was for the senior residents. So that is the real truth. Here's the issue. It clearly takes longer to finish the procedure, and there are a number of factors that may relate to that, including closing the skin. We've gone from a staple closure to more of a subQ closure. Clearly there are factors there, even though we compared BMIs. So that to me is the real practical information. This is a very positive study in many ways because it tells us that we're not implicating the delivery of the baby and that we are taking a little longer to get as good at the other parts of the procedure that matter.
So Haywood, what surprised you the most?
What surprised me, Kathy, really is that it didn't take longer. I'm there with the junior resident, allowing them to do the case, and we're teaching the whole time. So quite honestly, depending on who is doing the teaching, the junior resident, the senior resident, or the faculty member, that I thought it would even take longer because we all have our style. One of the things I tell the resident when I'm doing a case with them is, why are you rushing? Now that the baby's out, there's no need to rush. And so for that reason, I thought it would take longer.
Now, as an educator who is always ahead of the curve, what else do you think would be of interest to our readers?
Well, we need to begin to think more about simulation training for all of the things, procedural things we do. And we don't think about it that much for cesarean deliveries. But quite honestly, we've created a cesarean simulator that we're using in developing countries that is very well done, that teaches cesarean skills, just like we have for laparoscopic skills. And perhaps having the very young residents participate in that, or quite honestly, as we're thinking more about boot camp for those individuals who are going into OBGYN, just like we're doing medical records boot camps and so forth. If you know you're going into OBGYN, you are more likely to benefit from assimilation in the things that you're going to do every day. Why I think that's important. As you know, being a medical educator, we're taking people into training now as from medical school that really haven't done the amount of things that you and I did in medical school. When I was in clinic as a medical student, I mean, I did a lot. our students today, when I was a medical student doing deliveries, I did a lot. Our students aren't getting that time to do all of those things. So when we begin to put these into a boot camp format, as well as using simulation, we're going to make up for the fact that our people are less proficient early. You also know that we've gone into this different milestone project where we're going to have to evaluate how good our first years are at milestone 1. Well, we know they're coming into their training with a little less skill than we did. So we're going to have to put tools in place in order to make sure that they get there earlier, and by the end of their training, they're going to be just as good.
So I know mentorship is important to you. Do you have any thoughts on mentorship you want to share with our readers?
Well, you know, mentoring is everything, and there are all phases of mentoring. And we have a wonderful structured mentoring program that each class is assigned a group mentor. That group mentor is really about trying to make sure that they are part of a cohesive team, but there's also the person there as a buffer between the program director, between the chair, because the younger trainees now come in with a lot more challenges than I think we did. I mean, and I don't mean it in a bad way. The idea is that there are different generations, and they're not prepared to even work 80 hours. And so that mentoring becomes very important. Another thing about mentoring is that we all are going to make some mixed steps. That mentor needs to be there to give positive reinforcement. And that positive reinforcement every day. Everybody's used to making an A. Every day is not going to be an A day.
Haywood, thank you so much for joining us today to talk about yet another unintended consequence of duty hours. Though we're past 30 years since Libby Zion's death and at least 13 years since the duty hour regulations that ACGME first put into place, we still have a lot to learn about the effects of duty hours, not just on teaching and learning, but also on our patients. Thank you.